I'm an OBGYN and an addiction medicine specialist, but I do do a lot of pain management for our patients, and have worked to help develop a pain management protocol for intrapartum and postpartum women at Vanderbilt. And so some of what I'm talking about is going to be kind of based on that work. I have no disclosures. We're going to talk a little bit about the pathophysiology of common medications for opioid use disorder and how that affects pain management during labor and delivery and after, and how we, by optimizing the therapeutic alliance, we can set the stage for success with pain management. We're going to talk specifically about tips and tricks for pain management for both vaginal deliveries and C-sections, and then how we could develop some best practices at our settings and institutions around postpartum pain management. So, what are the challenges with pain in this population of patients who have opioid use disorder in the intrapartum, postpartum space? Shout it out. What's hard? Or is it easy and we've all got it figured out and we can go home?
Getting them to want to take pain medicine following a C-section.
Yes.
Worried about getting addicted again.
Right. There can be a lot of fear that is self-imposed. What else?
Presenting an acute withdrawal.
Yes. Yeah. So combining not only having to treat withdrawal, but also pain management at the same time can be super challenging.
Concern that they're, during a pregnancy, taking medications, and then now will my epidural work? Or like, how will I have pain management during labor?
Right, right. Is my pain going to be adequately controlled while I am in labor and after? Say it again.
Current maintenance there.
Yeah. So is their current maintenance going to be continued? Is it going to be supported? What about, will my pain be taken seriously? A lot of people are worried about that. And then it can just be hard to control someone's pain who has been sensitized to opioids. It can be challenging. It's not necessarily always simple as just giving them medication. So why is it challenging? People who have opioid use disorder often have a hyper-opioid tolerance, so they've been exposed to opioid medications or substances, and so they tolerate higher doses and need higher doses often to get effect from an opioid medication. They also might have lower pain sensitivity, which means that their experience of pain may be more sensitive than other people. And then part of that might be due to a concept called central sensitization, which has to do with those pain receptors in the body being upregulated. And so what happens sometimes in central sensitization is even sensation that isn't painful to other people becomes painful. And so we can see that in a variety of settings, but that can happen with people with opioid use disorder or chronic opioid prescriptions. And then also trauma. Trauma, for patients with opioid use disorder, they are at a higher risk of having experienced trauma throughout their lives in a variety of settings. Some of that could be sexual trauma. Some of that could be birth trauma. Some of that can be medical trauma. And that trauma sets the stage for higher anxiety, higher distrust of the medical system, difficulty to just hypervigilance. All of that working together can make it more difficult for pain to be controlled. With For opioid use disorder medications, so most commonly methadone and buprenorphine, but we do see people occasionally on naltrexone. We have our empty opioid receptors that are on the brain, but also are on the body, in the GI tract, and on the uterus even. And so methadone fits the opioid receptor perfectly because it is a full agonist. So it attaches itself to the receptor and activates it fully. Buprenorphine is the right shape to attach to the receptor, but it only partially activates it, which is part of why we use it so effectively in treating substance use disorder. And then the naltrexone goes onto the receptor but doesn't turn it on. So it basically kind of gums it up and prevents anything else from occupying it. So I think it's important to keep in mind that when people are coming in for delivery, if they are on methadone or buprenorphine or naltrexone, that is going to impact how any opioid you give them, how effective or ineffective it is going to be. So if you do not remember anything that I say today, please remember this. Medications for opioid use disorder do not treat acute pain. So not that we can't take advantage of them, but we cannot expect that someone's methadone or buprenorphine is enough to control any acute pain that they're having, whether that is from a C-section or a trauma or whatever it is, like there are surgery. Their medications for opioid use disorder keep them from getting sick, keep them from having withdrawal, keep them from having cravings, but they are not enough to treat the new pain scenario that happens from a surgery. So the general principle is that we should be continuing methadone or buprenorphine depending on what they are on. And I will talk more about that. When we first really started using buprenorphine in the obstetric space, there was some thinking that, and I think there's still some kind of people that may be still using this in a surgical space, but there was some thinking that we needed to stop buprenorphine prior to delivery, especially if someone was planning a C-section, so that the buprenorphine wouldn't interfere with pain control. I think that that is pretty much not how most people are practicing these days, and most institutions are having people continue their buprenorphine prior to any kind of scheduled surgery, including C-sections. So that makes things less complicated in some ways. If someone is on naltrexone, that has got to be stopped before they have a surgery. Naltrexone, because it's that full opioid blocker, it is going to make it very difficult for any opioids to bind to those receptors and for them to get any relief from an opioid. So if someone is being prescribed naltrexone, whether that's the injectable naltrexone or the oral naltrexone, that really has to be stopped. Thus, we don't typically, at least in our practice, see a lot of people on the Vivitrol or naltrexone injection, but if I had someone who was pregnant and on that, they would need to stop that by 35 weeks. And usually people transition to the oral naltrexone at that point if their goal is to continue on naltrexone. And if they're on oral naltrexone, they need to stop it at least 48 to 24 hours before their scheduled procedure. But what do we know about labor and delivery? All deliveries are scheduled, everything is planned, every pregnancy delivers at term, and it's easy peasy. I talked a little bit about this earlier, but I'm going to go into it a little bit more. So we talked about how methadone is a full opioid agonist and occupies those opioid receptors in the same way that oxycodone or heroin or fentanyl does. It is long-acting, so it is designed to be taken once a day. So you get your dose in the morning, and then you don't need it for another 24 hours. I would say pregnancy is an exception to this. It's because of the metabolism of pregnancy, some pregnant women will need twice daily dosing with their methadone in order to prevent withdrawal or to prevent cravings. So it is not uncommon if you have a person coming in on methadone to deliver, they might be on twice daily dosing, and the methadone clinic that they go to should be able to confirm that and to confirm their dose. Methadone is long acting, and taken orally, it takes about 30 to 60 minutes before for onset of action. And so if someone is in acute pain after a C-section and they get their morning methadone dose, that's not going to relieve their pain right away. And it's maybe not relieve it at all because this is their maintenance medication. It's metabolized by the liver. It has a half-life of 8 to 59 hours, so a pretty long half-life. And then all methadone outpatient has to be dispensed by a licensed opioid treatment program. And in Middle Tennessee, there are 7 of them for all of Middle Tennessee. And so depending on where you live and where you're practicing, there may be more or less. But if you have not met your local opioid treatment program folks, I would highly recommend you connect with them. It's super helpful in terms of getting records and documentation and just coordinating care. And then buprenorphine is a partial opioid agonist. So remember, it was those little dots that were occupying that receptor. And it is a full kappa opioid agonist or blocker. And the kappa receptor, I like to think of that as the receptor that really causes euphoria and that kind of like feeling of being high. I'm sure it's more complicated than that, but I am not a neuroscientist. It is an office-based treatment, which is what makes it, in Tennessee, the more common opioid use disorder treatment, is because it's more accessible than methadone. It can be given sublingually or a long-acting injection. Sublingually, the onset of action is 30 to 60 minutes. And sublingually, the duration of effect is about 6 to 12 hours for less than 4 milligrams, and 24 to 72 hours for higher doses. Similarly to methadone, pregnant women often need split dosing for effectiveness of buprenorphine in pregnancy. And so while a non-pregnant person would probably usually be taking buprenorphine once daily, during pregnancy, we frequently split the dose for it to be more effective. So how do we establish a therapeutic alliance? So we are goal setting, making sure that the patient their goals are being heard and listened to, and then the patient understanding what the medical team goals are, and hopefully there's a line, hopefully so they're not in conflict, but we can't always assume they align. And then also making sure that we're just introducing ourselves, we're establishing rapport. That goes a long, long way. So the basics that help our patients see that we recognize their humanity and we are going to meet them with our humanity. So we're having this shared space, shared interaction, a commonality, helping them see that we value them and value their experience. And one of the ways we can also do this antepartum is explicitly discussing pain management before people get to the hospital, because I can guarantee you they're worried about it. They're thinking about it. How will my pain be controlled? Will I be taken seriously? Is my epidural going to be effective? I've heard that I'm on buprenorphine and it's going to block all my ability to have pain relief. You know, all of these misconceptions that we can do a lot by allaying those fears and educating antepartum. And then making sure antepartum we're talking about their desires around pain management, especially if they're going to have a C-section. There are people who have opioid use disorder who were their care plan and their priority is to avoid all opioids. And that should be validated. If that is part of their plan, we want to try to honor that plan and also acknowledge the challenges that might come up and what would that look like and what would those conversations be if their pain was severe and that needed to switch. Inquiring on what their fears are, what are their concerns. So all of those conversations, antepartum, super important. Creating trust, and that starts the moment you walk in the room, as you were alluding to. And so part of that creating trust is about acknowledging what might be challenging. So we're not going to pretend like that pain control is not an issue. We're not going to pretend like people never have problems with pain control if they're have a history of opioid use disorder or on medications for opioid use disorder. And that goes a long way in creating trust, of being honest about what can be challenging and then what we're going to do about it, how we're going to work. And then once we are in the hospital at admission, so again, discussing plans for pain management. And how many of you in your hospital setting, an anesthesiologist sees every patient that gets admitted to L&D? Oh, just a few. Oh. For those who don't, when does the anesthesiologist get on board? Never? When they want their epidural. Okay. So that might be an interesting QI initiative. An opportunity that I think all patients benefit from is having an anesthesia evaluation prior to things being urgent or emergent or pain being out of control, because those conversations around pain relief and potential challenges and what can be done can be happening while patients are able to have a conversation about it. Asking specifically about a patient's concerns or worries, and then continuing to address that throughout the admission. And then listening if someone says they're in pain. And it sounds really simple, but we all get busy, and it is easy to kind of dismiss when we have a long list of other priorities. So these are the basics. The basics that we are helpful to offer to patients with an addiction history is to reassure them that their history is not going to prevent them from getting adequate pain management. And just saying it out loud can make all the difference, because people are thinking it. Even if it's never mentioned, they're probably worrying about it. The second thing is continuing their usual dose or its equivalent of their medication for opioid use disorder. So we need to make sure that we're able to continue their methadone or continue their buprenorphine products in the hospital. We really want to be trying to verify their dosing of their methadone or buprenorphine. Usually methadone clinics will provide a sheet of paper that patients are given to take to the hospital when they deliver. So usually a patient should have that, but if they don't, every methadone clinic has a 24-hour number that you can call and verify their dose. And then the buprenorphine dosing is easier to verify through CSMD, through our Tennessee State database, so that's a little bit easier to be able to confirm dose without having to call like with methadone clinic. It is also best practice to notify the addiction treatment program or prescribing physician that the patient has been admitted and discharged from the hospital. I think it's important to be realistic, like how frequently do our teams have the time and capability to do this, but I think that ideally this would happen and help coordinate care and make sure patients are getting their appointments more quickly postpartum. And then this is also really helpful, is to make sure the patient is getting a list of everything that they've been prescribed or given inpatient, and so that includes benzodiazepines and opioids, because their follow-up drug testing may show that they are positive for those things, and that may impact their care. So how do we navigate pain management for patients with opioid use disorder? Being non-judgmental. That's super important. And that by being non-judgmental, we can help people be less anxious. And we know that the more anxious someone is, the more pain they're going to experience. So relieving that anxiety, helping them feel safe, is going to help their pain control. We need to be using other analgesics besides opioids also to aggressively treat the painful condition, but we're going to probably need to use opioids also if they're having a C-section. And so we'll talk more about multimodal analgesia and what that looks like. And then really understanding that their pain sensitivity is going to be impacted by the medications that they are prescribed and take every day. And so they may need higher doses of whatever opioid you're prescribing, and that doesn't mean that there's something wrong with their recovery. It doesn't mean there's something wrong with them. It doesn't mean that they're drug seeking. It just means that they are in pain and need more effective pain management. And so that may be giving them higher doses. It may mean switching the type of opioid. It may mean administering their opioid at shorter intervals, even every 2 to 3 hours rather than 4 to 6. We can help our nurses by making these orders scheduled rather than as needed. And then we want to avoid using the medications like Stadol and Nubain, because those can precipitate withdrawal for people who are on opioids chronically. So what is multimodal analgesia? We're attacking the pain from all different angles. And so there are many different types of pain, and there's pain from our organs, there's pain from trauma to the skin, there's nerve pain, there's all sorts of pain. So we want to take advantage of all of our different tools to attack the pain from every different angle. And so most of our patients in an obstetric setting are getting an epidural or a spinal. And then definitely for our vaginal deliveries, we want to really use our NSAIDs, including Toradol, but also for our C-sections. And so scheduling our anti-inflammatories, scheduling our Tylenol, super important. It's one of those things that patients don't often believe is going to work, but it makes a huge, big difference. And so educating people, and I think a little education around this goes a long way in helping people understand that pain can be treated in lots of different ways, and that we need to use a lot of different tools, including our NSAIDs, even if they say, oh, NSAIDs don't work for me. Ibuprofen never works for me. Using gabapentin to help with nerve pain. We can use muscle relaxers. That can also be really effective. And so often with our patients who have opioid use disorder, we're using all of these things to try to create a cocktail that is going to control their pain adequately. Some people can have a benefit from regional anesthesia blocks. So typically the block that we use most commonly is a transabdominal plane block. So using lidocaine injected into the abdominal muscles in a specific plane to help provide a longer acting block there around the incision. And then some pretty easy low intervention things like early ambulation, helping people getting up and walking and moving. And then also abdominal binders, making sure that we're giving people who have C-sections abdominal binders so they can get some extra support so that they can get up and moving and get out of the bed. So when we get admitted to labor and delivery, we are going to create a therapeutic alliance, and we are going to screen for substance use disorder with a validated screening tool, not with a urine drug test. We are going to get their history, and that's going to include a substance use history and their last use of any substance. We're going to verify their medication if they're on methadone or buprenorphine. And then when would we do a urine drug test? Well, we would do a urine drug test if that's going to help us medically and if we have consent from the patient. And I know I'm talking about an ideal world here, but I'm manifesting all this into existence. And then our anesthesia team is going to come in because they see everybody on labor and delivery. And they're going to help the patient make a plan regarding their pain management. And then they're going to have their pain really well controlled, and they're going to go home really happy, and then their Press-Ganey scores are going to be super high, and and then leadership will be happy. Work with your anesthesia team to create a care pathway for patients with opioid use disorder who have C-sections. And I will tell you, our anesthesia team has some data on this, and maybe next year I'll have them come to share that with you. But they created this pathway, and our complaints about inadequate pain management plummeted. And part of that care pathway is the multimodal analgesia, but part of it is that our anesthesia team rounds on our postpartum patients with C-sections every day that they're in the hospital. And what that means is their pain management gets titrated much more aggressively and much more frequently than if they never saw an anesthesiologist again or only saw them once. And it has made all the difference. So if you have that opportunity in your setting and you have an anesthesia champion, I would highly recommend that you do some advocacy around that, because it makes a big deal. It makes a big difference. So for vaginal delivery, so someone coming in for vaginal delivery and they are on methadone, what do? You continue their methadone at the current dose. It is totally up to them whether they have an epidural or not during their vaginal delivery. And we're going to avoid the nalbuphine and the butorphanol, avoid Stadol and Nubain. If they're on buprenorphine, we're going to continue their current dose. If they're going to have a long labor, it wouldn't be a bad idea to split that dose into Q6 or Q8 hour dosing. There is some analgesia properties that buprenorphine has, especially with higher doses, and so we can take advantage of it by more frequent dosing. But if that's not possible, you don't have to, but you can. Regional anesthesia again, and again, avoid your Stadol and Nubain. So for someone who has had a vaginal delivery uncomplicated, we're not talking about our 3rd and 4th degree vaginal lacerations or people with endometritis or other complications after vaginal delivery. But we're going to continue their medications for opioid use disorder. We're going to schedule NSAIDs and Tylenol, and we're going to avoid opioids. We shouldn't need to do opioids in this setting. C-section is a whole different ballgame. So similarly, for methadone and buprenorphine, we're going to continue their doses if they're having a C-section, and we're going to have them continue their medicine up until the day. They're going to take it the day of their C-section, just like they would otherwise. They can have regional anesthesia. We can do the local anesthetics with the TAP blocks. And then we can also consider doing intrathecal opioids that will last like a full 24 hours after delivery, and that can be super helpful, and that can be navigated by your anesthesia team. And then after they've delivered, we're continuing their methadone or we're continuing their buprenorphine. There has been some anesthesia literature that suggests that if we increase the buprenorphine by 50%, increase their dose postpartum, that can help control their pain and can help potentially avoid other opioid use or need for other opioids. However, I would say that this can get people into kind of a bind after they're discharged from the hospital if you're not coordinating with their outside person who's prescribing their buprenorphine, because if they go home with their home supply and they start taking 24 milligrams and they were only prescribed 16, they're going to run out early, and then they're not going to get a refill, and they're going to have withdrawal, and they're going to be miserable, and then we don't want that. So if that is done inpatient, it's really important to make sure they go back to taking their home dose, or you coordinate with their outpatient provider to temporarily increase their dose. If they do not get intrathecal opioids, they may need a PCA for 24 hours postpartum. Scheduling our NSAIDs, using gabapentin. And if we're going to use short-acting opioids, which almost all of our patients, in my experience, end up needing after a C-section, choosing hydromorphone can be helpful rather than oxycodone or hydrocodone. And I'll tell you a little bit about that and why in a minute. I don't think that in Tennessee we're seeing a lot of naltrexone in the peripartum period. Are you all in Knoxville? Okay. So I like this chart. It's from Boston Medical Center, and they did a research study looking at naltrexone in pregnancy, but it has a really good algorithm on care pathways for patients who are on naltrexone in pregnancy. So I would encourage you to look at this if you do have someone who comes in and is on naltrexone. But if you have someone who comes in who is on the injectable naltrexone, which is called Vivitrol, and they're coming in for delivery and they've had an injection within a month prior to when they're coming in for delivery, an anesthesiologist needs to manage their pain, because they are going to require, if they're having a C-section, they're going to require very high doses of opioids in order to control their pain, and it can become a medical emergency. So just kind of put that in the back of your head. But we don't get a lot of pregnant patients who are prescribed naltrexone. So what if they're still hurting, right? Like, you did all the things, you have your protocol, they're still in pain. So I think number one is validate. Say that you believe them, acknowledge their pain, because there's so much fear and anxiety around not being heard that you can, if you just give them the opportunity to describe their pain, describe what's going on, and you simply say, I know you're hurting, I believe you, I'm sorry, we're gonna work on it, you can see they relax. And it just changes the dynamic than trying to argue with them and convince them that they're not in pain, because that never works, right? Make sure that they're getting examined by a midwife or a physician to make sure that we're not missing something. Like, what else could be causing the pain? Do they have a developing endometritis? Do they have a hemorrhage that we're not recognizing? You know, there are all sorts of things, serious complications that can happen postpartum that we don't want to miss, because we're assuming that someone is drug seeking, or we're assuming that their opioid tolerance is really high, and that's why their pain is out of control. I've seen people who have had severe pain for one reason or another, and it's been dismissed because of their opioid history, and it turns out to be something pretty severe, and so we don't want to do that. Making sure, re-review, are we taking the multimodal analgesia? Are they really getting all their medications scheduled? Are they ordered in a scheduled fashion? Which of these medicines can we increase their dose? Which can we increase the frequency? Do we have anesthesia colleagues or pain management colleagues that we can bring in to get more ideas? And so usually doing a combination of these things is enough to help someone get through that acute postpartum pain. So for discharge, for vaginal delivery, we're going to make sure we're discharging them with their NSAIDs, a stool softener, because constipation is really uncomfortable and painful, and so that's going to help with their pain control. making sure everyone gets naloxone at discharge, and we're going to be talking about a way to make that even easier for participating hospitals very soon. And then if they should really be following up with an obstetrician and or their addiction medicine specialist in 1 to 2 weeks postpartum. And then if they have a C-section, they're going to get all the same things as a vaginal delivery, plus their gabapentin, if they're taking it at a hospital, plus or minus their short-acting opioid. And in general, I would say patients need to have a short-acting opioid for 3 to 5 days after discharge, kind of depending on how long they've been in the hospital. So if you're discharging on day 2, then you probably want to go towards the 5-day. If you're discharging on day 4, you want to go towards the 3-day. But there's a lot of good data about tailoring opioid prescriptions and really looking at the amount someone is taking in the hospital to help determine how much they're going to need afterwards. So, which short-acting opioid do we use? I would say most commonly in the OB world, after a C-section, we use hydrocodone or oxycodone as kind of a toss-up, I think, depending on your institution, which one you use. Is anybody using anything else besides those two for your postpartum C-sections? Yeah. But I would say we should get more comfortable with using hydromorphone for our patients with opioid use disorder. And I think this table demonstrates this pretty well. So these are the binding affinities of these drugs for the opioid receptors and how strongly they bind to the opioid receptor. And so you can see in the lower the number, like the stronger the binding affinity is. And so buprenorphine is very strong. It really binds to those opioid receptors. And then look where your hydrocodone is. It's way down here. Oxycodone is just right above it. And so hydromorphone is much more likely to be effective for someone who is using buprenorphine than hydrocodone or oxycodone. So I think something to really keep in mind. And then the sufentanil is like more like the synthetic fentanyls that are on the streets. So you see how strong of an opioid binding affinity that has. So I think it helps to kind of understand the science behind why we might not be getting the effect we think we should be having with the oxycodone and hydrocodone. So what are some opportunities for improvement that you all kind of see around pain management in your setting? So I'd recommend engaging your anesthesia colleagues. I think it can be, if you can find an anesthesia champion, it's a game changer. You know, someone who is passionate about this patient population, who really cares about this issue, and putting those two worlds together, those OB worlds and those anesthesia worlds, really can make all the difference. Making sure that we have education that happens not just once or twice, but routinely with all of our OB colleagues, all our nurses, all our physicians and midwives. So making sure that we're all on the same level playing field around how people with opioid use disorder, their pain management needs, the chronic medical nature of opioid use disorder, and ensuring that we are really promoting a culture of respectful care. I mean, this goes for all patients, but we know that patients with substance use disorder are frequently not given the respectful care that we would like to be giving to everybody. And we can do that in a number of ways, but we can get feedback from patients in particular. We can do that through discharge surveys, either through for however you have that already set up, but that can be really helpful to get a sense of how effective your interventions are, and then creating these intrapartum and postpartum care pathways and best practices so that everyone practicing in your institution knows what's expected, and there's a resource to look at and see, like, this is how we do things, and we all agree on this.